Thank you so much, Susan, and thank you for the opportunity to be here. I just want to add a little bit to my bio, so it's a little bit outdated. I do not work for Zoetis any longer. I'm back in practice as a surgeon in North Carolina. Also a paid consultant for a few different companies, and I'm very, very honored to get to be here to present on behalf of Zomedica and talk about shockwave and pulsed electromagnetic field therapy. And so the outline for today is I'll be perfectly honest up front. The majority of this presentation will be on shockwave. I have quite a bit of experience with it dating back to my time at the University of Florida, and it's been really integral to my practice both on the surgery and on the rehab sports medicine side of things. But we'll also round out by briefly touching on pulse electromagnetic field therapy. I do use PEMF. I honestly have it for myself and my own dogs at home. So getting started, first of all, what is shockwave therapy? And whenever I'm talking to clients about shockwave therapy, I always have to say, the word shockwave comes off a little bit off-putting, right? I mean, always have to clarify, we are not shocking your dog or cat. What a shockwave is a really intense sound wave. So that's what I tend to tell clients is it is about 1,000 times the magnitude of ultrasound. But what we are talking about is high intensity sound waves. And to be a shock wave, there's there's some physics that are really specific to it. And believe me, we are not going to get into all the nitty-gritty details of physics, but to make a shock wave, and what a shock wave truly is a wave, a sound wave that has a very, very rapid rise in pressure, followed by a very rapid decrease in pressure. That negative pressure creates this kind of release of energy. And that release of energy is kind of what winds up giving us the downstream effects of what we're looking for. So that kind of physics of the shockwave, really rapid rise, really decrease in pressure. There's a few other variables that come into play when we're talking about shockwave therapy, shockwave mechanics, but also when we're trying to compare different shockwave units, or we're trying to look at the research and say, can we take the results of this particular research study and conclude that this other shockwave device or this other shockwave protocol will be equivalent? And if you're familiar with laser, it's the same sort of challenge and the same sort of ideas that we focus there. There's a lot of different variables. Again, not going to go into all of the different details here, but we have whatever that peak energy is. How quickly does that energy increase? What is that total, what's called flux density? You can think about that like the dose. What's the total dose that we're giving? How is that dose spread out over the tissue? How deep does the sound wave get? And then how many pulses are we giving? What's the frequency of the pulses, meaning how many pulses per second? And then kind of zooming out, well, how often are we going to treat the patient? So there's a lot of different variables that come into play when we're looking at, like, does this work? How does this work? How do we use it most effectively? And then to make matters potentially even more complicated, we have at least 3 to 4 different ways that a shock wave can be generated. So these are essentially the different types of machines that are out there have different ways that they generate that shock wave. Electrohydraulic, that is the PulseVet product, is using electrohydraulic, and I will be honest that is the only it's the only shockwave device that I have any experience with, and it really is the one that has the majority of the research. So that's what we're mostly going to focus on today. So electrohydraulic does result in a specific type of pressure wave, and that is going to be different than electromagnetic. Which is going to be different than piezoelectric. And then you may also hear about radial shock waves out there. Now, technically, a radial shockwave device doesn't actually make that true shockwave. So whether it works or not is still yet to be determined. There is some evidence to show that potentially there's something to radial shockwave. But what we're going to focus on, pun kind of not intended, but we're going to focus on the electrohydraulic device because, again, that's where the majority of the research comes from. And so when we look at the mechanism of action, how that sound wave ultimately provides a therapeutic outcome that we're looking for, If we give one big fancy word to that process, it's called mechanotransduction. And in other words, we are taking one form of energy and transforming it or transmitting it to the patient tissue to ultimately have an end result. And so all of this starts by plugging our shockwave into the wall. So we start with electrical energy. That energy goes into our shockwave device, where there's actually pretty high voltage that occurs in here. And that is transmitted out to the trode head. So we talk about the kind of the device that you actually administer the shockwave to the patient, called a trode. And inside that trode, there is liquid, and this high voltage gets transmitted out to that end of the trode, and there's a spark that's generated. And then there's some reflecting devices inside there, and then ultimately it creates this shockwave, what we're aiming for. And depending on the trode that you're using, there are going to be different tissue depths. There are a few different trode heads that can be used with the PulseVet. There's ones that get as deep as 2.5 millimeters. There's ones that get as deep as 40 millimeters or 4 centimeters. There's equine devices that get even deeper. And then there's also a trode called the X trode, which has a sort of different shape to its waveform and its focus area. And that particular trode head is the one that doesn't require sedation compared to the other ones. But so we've chosen our trode head based on our tissue depth or whatever we're faced with. That spark is generated in the trode. It sends this shockwave out. We do want to use ultrasound gel, and I almost always shave and use alcohol and then ultrasound gel to help that contact between the trode head and the tissue. Just think about the same way with your ultrasound, your diagnostic ultrasound. We're always going to need to allow that sound wave to get through the tissue. So we apply it to the tissue. That sound wave transmits through the tissue, and that focal depth is ultimately based on the trode size. But the energy that is kind of in that sound wave tends to get released at what's called the area of maximum acoustic impedance. And what that means is where you have two different tissue types that come together. So a great example is where a tendon attaches to a bone. That's going to be where there's going to be a great opportunity to release a lot of energy at that interface. So the energy is released in the tissue, and I think about it like a little punch to the cells. The cells are literally kind of getting shooken up. This is that mechanical stimulation. So the cells are stimulated, they are shooken up, and then those cells then release a variety of different cytokines and mediators. And this is where ultimately we have our downstream effects that we are using shockwave for from a therapeutic standpoint. So for example, we have the release of BMP2, or bone morphogenic protein, that is going to help contribute to osteogenesis or helping bone heal. We can get the release of TGF beta, that is also going to play a role in kind of various tissue healing. PCNA, VEGF, ENOS, all of these are also going to contribute to essentially tissue healing, neovascularization. So now you can think about, well, we've got these release of all these cytokines. Great opportunity for using shockwave is going to be when we're looking for either bone or soft tissue healing. So if we summarize that in terms of mechanism of action of shockwave for tissue healing, we have that electrical energy converted to acoustic energy, or sound energy, which is converted to mechanical energy, which then causes the cells to express their various different cytokines, bone morphogenic protein, VEGF, and then ultimately we have improved or increased soft tissue and bone healing. And so we will get to some examples and discussion about how we would choose and how we would use shockwave specifically to encourage various different soft tissue or bone healing opportunities. We can also use shockwave to manage pain. And I mean, pain often goes hand in hand with our soft tissue injuries, but sometimes we're also just using it for truly pain management. The mechanism of action here is a little potentially less well understood, but there's a few different kind of theories. One is it can help prevent production and propagation of a pain signal. And one way it can do that is really kind of decreasing the nerve conduction velocity, slowing down that signal from the periphery up to the brain so we don't perceive that pain signal. It can also help reduce substance P and CGRP. Both of these are kind of pro-inflammatory mediators that can get released in chronic pain states. Plays a role in descending inhibition. That's the kind of arm of the nervous system that kind of can dampen down a nociceptive signal that's going up to the brain. Can increase serotonin release, and so that actually plays a role in that descending inhibition, and also can play a role in the perception of pain. So what those nociceptive signals transmit, we don't feel that pain signal quite as intensely. And then can also improve blood flow and improve lymphatic function, which can then help drain inflammatory products and reduce edema. So sort of a roundabout way of reducing pain. And so we also will, because of its tissue healing, because of its pain relieving effects, and because of some other mechanisms, we often will reach for shockwave for management of osteoarthritis. And there is research, mostly in rodents and experimental models, that show that shockwave can potentially be chondroprotective, meaning it can reduce cartilage and matrix degradation in the cartilage, can increase chondrocyte proliferation potentially. Now that is mostly in experimental models or in vitro, reduce chondrocyte apoptosis, can modulate inflammation. So can reduce MMPs or matrix metalloproteinases. Those are guys that help propagate the inflammatory process that's going on and the degradative process of OA. Can potentially improve subchondral bone microarchitecture. And there's research that suggests that shockwave can be beneficial both in the early and late stages of OA through not only its interaction with the joint tissue, but also through those mechanisms of reducing pain. So that's the real sciencey stuff. That is the mechanism of action of how it works, the kind of physics, which, obviously I glossed over. What I think is a little bit interesting is actually to go back and think of, like, where did this come from? How did we get to here talking about shockwave therapy? And actually the origin of extracorporeal shockwave therapy that we talk about now was actually with lithotripsy. So back in the 1980s, really, if you're talking about shockwave, that was lithotripsy. Lithotripsy now is the standard of care for percutaneous treatment of urinary stones, so kidney, urinary, and even bladder, biliary stones. What they found, though, when humans were being treated with shockwave therapy for their kidney stones, is they actually noticed that there were some changes to the bone in the field where they were being treated for their kidney stones. So out of that, there started to be some additional research into those, the effects of shockwave on bone. And so initial animal studies showed that there was increased osteoblast activity and increased bone formation. And that helped to explain some of the changes that they were seeing radiographically on the humans that were being treated with lithotripsy. So out of that, they said, well, why don't we develop a device that is specifically for musculoskeletal treatment? And so that first started in the early 90s. And in 1998, there was kind of the first organization that came together, the International Congress of the International Society for Medical Shockwave Therapy. And this website is actually really interesting. If you want to geek out about shockwave, I strongly encourage you checking this out. The QR code is there on the slide. Lots and lots of really interesting information about where shockwave is on the human side. And I'm going to show you a slide in a few slides coming up that you'll see they are using it for a lot more indications than we are in our patients. So in 1999, that was the first veterinary specific device that was introduced, and that was the Echotron, so specifically for equine patients. And then in 2008, there was the first small animal device, and that was actually when I started using shockwave, was back in 2008. And fast forward since 2008, now we have multiple peer-reviewed publications specifically using the Versatron or PulseVet device, which for me is one of the reasons that I really enjoy talking about this subject, is because of all of the therapeutic modalities out there, I believe this is the one that we have the most substantial evidence with the actual device that we want to be using in practice. We're not having to extrapolate from translational medicine or from other devices. There's a pretty decent amount of research with the PulseVet device. As of now, though, there are actually multiple other shockwave devices out there. And this is where I just want to reiterate, it's not to say that they don't work. We just can't necessarily extrapolate the information we have from the PulseVet unit to other devices out there. So indications for shockwave on the human side, this is where I mentioned lots of interesting articles on that one website. Shockwave started with all about bone, but then pretty quickly moved over to treating soft tissue injuries. So chronic tendinopathies, plantar fasciitis is where there's a lot of support. There's a lot of success using shockwave to treat plantar fasciitis in humans. Also for tennis elbow, chronic calcifying rotator cuff, Achilles, patellar, so any of these chronic tendinopathies. Of course, also for bone healing, it's used for low back pain, it's used for osteoarthritis, and for delayed non-healing wounds such as diabetic ulcers. But also, it is used for erectile dysfunction, and that is actually, many actual men's clinics around the country today are offering shockwave therapy for erectile dysfunction. I'm just going to leave that there. Moving on, some of the new areas that are being explored in humans are actually using it in heart disease to stimulate some of the blood flow, in aesthetics, such as for treating cellulite, body contouring, potentially for stroke, so transcranial administration, acute spinal cord injuries, metastatic lesions. All of these kind of have question marks, and they're certainly not ones that we have any evidence in our veterinary patients for using, and not ones that I would recommend at this point. I'm not recommending that we're treating acute spinal cord injury with shockwave, but maybe one day we'll learn more. The indications as of today in canine patients include tendinopathy, and there's at least 3 studies showing the benefit of, again, specifically the electrohydraulic PulseVet unit in treating tendinopathy. And bone healing, and we'll talk a little bit more about those studies coming up. Osteoarthritis, and the osteoarthritis articles also include some of the non-PulseVet units. Post-op pain, and then also for back pain. So for me, as in my practice, doing both surgery and a lot of rehab sports med, one of the most challenging conditions that we are faced with are tendinopathies, especially shoulder and Achilles tendinopathies. And this is the area that I think I've probably used shockwave the most. And so what I want to talk about, I'm going to give you some case examples. We've got to start at the beginning, like, what is a tendinopathy? There is this tendency, I think, for people to refer to a tendon injury as tendinitis. But if you remember, itis implies inflammation. And usually when we are faced with a tendon injury, unless it is very acute, what we are actually dealing with is a failed healing response. And it is stuck in this non-healing state that, if you look at it histologically, there is not an inflammatory process going on. So a more appropriate terminology when we're dealing with these chronic tendon diseases is either a tendinosis or tendinopathy. There may be periods of flare-up of inflammation, but in general, we are dealing with this chronic non-healing wound, if you will. The pathophysiology of tendinosis tends to be chronic overuse injury. So the classic example is kind of tennis elbow in humans, but I will tell you that I have tennis elbow or lateral epicondylitis, and it's not from playing tennis. I developed it from really just poor ergonomics. And what that means is on the lateral aspect, kind of the extensor tendons where they originate in my elbow, can have some really, really significant pain there. And so that is a very common condition in humans. But in dogs, we also have chronic overuse injuries, really commonly in the shoulders. From the sports medicine side, we see that pretty often. And there can be other tendons that we get overuse injuries in. But what I also want to highlight is that when we unload a tendon, meaning when we put a joint in a bandage or a cast or a transarticular fixture, anything where we unload that tendon and we don't allow it to function, that actually results in the same histologic changes that we see with overuse injury. So there's these changes to the cellular level that result in decreased mechanical strength. So there's a picture here of a dog that had an Achilles tendon injury, and it was an acute injury, but then put in a cast after surgery. I tend to use shockwave on these Achilles injuries, or any, ideally anytime we're going to unload a tendon, to help mitigate some of those negative consequences, negative changes that are going to happen if we unload the tendon. So when we have that tendinosis, and I'm going to say whether it's an overuse injury or potentially an unloading situation, we have decreased vascularity. So tendons in general have pretty poor blood supply, and then it can potentially get worse. But then if in that healing, there might actually be hypervascularity, and there might be neo-innervation. And so more nerve endings in there might mean that that's potentially why there's pain associated with it. And ultimately, if there is chronic pain being induced from an injury, there's going to be chronic remodeling of the pain pathways. And in other words, there's going to be maladaptive pain that develops because of this unmanaged pain. And then on top of that, if there are acute episodes of inflammation, that can also result in kind of a flare of pain. Historically, traditionally, treatment of tendinopathies have been rest and NSAIDs. Hopefully, now you recognize that rest and NSAIDs are probably going to be pretty ineffective. If we don't have actually acute inflammation going on, NSAIDs probably aren't doing a whole lot to truly manage the pain, and certainly nothing to heal the tissue. Resting, there is a component of rest that needs to happen, but strict rest is actually going to be detrimental to that tendon healing. Injecting a tendon with steroids is going to be definitely negative. That is certainly not anything that's recommended anymore if we're trying to heal a tendon. Sometimes we're going to choose tenotomy or surgery, such as for a biceps, if we have a chronic biceps tendinopathy or tearing away of that biceps tendon. Sometimes actually, admittedly, surgery is the best option. But if we think about the traditional rest and NSAIDs, my argument is I think we can do a whole lot better. And it starts with appreciating what we're dealing with and characterizing that lesion as generally a non-inflammatory condition. However, we do need to control pain, do need to manage pain. But ideally, hopefully, you're trying to stimulate that tissue to heal. But we also have to influence healing both from a interventional standpoint and also from avoiding the things that cause the injury in the first place, avoiding the things that exacerbate the injury. And overall, we have to have realistic time frame and realistic expectations for that healing. So my recommendations when we're talking about a tendinopathy, there's kind of three really important components to it. Number one is stimulating healing. And in my hands, I'm going to do that with shockwave plus or minus PRP. I'm going to always recommend some form of therapeutic exercise, potentially manual therapy if we're seeing that patient back on a regular basis. But for me, actually, shockwave is the primary means of the stimulation of healing. But probably the most important, yet the hardest part of managing a tendinopathy is protecting it from re-injury. So we need exercise. We need that tendon to be loaded, but we have to modify that activity. And we have to have really honest conversations with the client. If you continue to let your dog do the things that exacerbate this injury, it's never going to heal. We can do as much shockwave as we want. We can inject all the things we want. If we don't allow that tendon the environment and the opportunity to heal, it never will. And then we have to gradually reload that tendon. We have to gradually return them back to that whatever athletic state they're getting to. And that's where therapeutic exercises are really important. And this is where working with a rehab therapist that can guide the dog and hold the client's hand is really important, because these take a long time, like a long time, and sometimes never fully heal. Sometimes that patient can get back to a really high level of activity, but their threshold for re-injury is always lower. So when I think about using shockwave for tendon healing, as I mentioned, I'm thinking of it as it's kickstarting the healing process. So we're administering that sound wave, that shockwave. It is shaking up the cells in there, and we're having the release of those cytokines, and it's restarting that healing process. It may help regulate blood supply to the tendons, can help with pain management, and there's potentially a regenerative component to just using shockwave alone. So one of my early cases that I used shockwave in, maybe not super early, but one of I would say a success story. It was a 2-year-old male-neutered coonhound with a 9-month intermittent forelimb lameness. That's actually pretty young. So he's definitely on the young side of the dogs that I've seen with chronic tendinopathies. But he was a bit of a working dog. Shockingly, non-responsive to NSAIDs and rest. On physical exam, he did have pain at the supraspinatus myotendinous junction. He had a positive biceps test, which means when we stretch the biceps, there was discomfort there. He had a tight biceps muscle, did also have mild muscle atrophy of those left shoulder muscles. So he had an MRI. Now, you don't always have to do an MRI. I just happened to be working in an area, in a facility where we did a lot of MRIs, and we were able to MRI him and found moderate insertional tendinopathy of the supraspinatus, mild biceps tendinopathy, and moderate tendon sheath effusion. So this was supportive of our physical exam findings. We did also do musculoskeletal ultrasound. So I had the great fortune of working with a really talented radiologist that did a lot of musculoskeletal ultrasound. And the conclusion from that was that there was a moderate insertional tendinopathy of the supraspinatus with mild biceps tendinopathy. So ultimately, we're dealing with 2 different tendons of the shoulder, really, really, really common. So I had the clients fill out a canine brief pain inventory. So if you're not familiar with this, this is a client questionnaire that is validated through a variety of different mechanisms, but can track response to treatment. And so overall, pretty high numbers on the canine brief pain inventory, indicating that Musket was really quite painful. And overall, his quality of life was considered fair, which is kind of so-so. So his treatment was 3 treatments spaced out every 3 weeks, and that tends to be my kind of protocol. We used what was called the R20 Trode 800 shocks E6. And he did also have an exercise program. So that's a pretty kind of standard protocol there. Rechecked Musket regularly throughout this, but at his 10-week recheck, his lameness was improved. There's still a very mild lameness, but he was never non-weight bearing. He still did have some discomfort, but it was improved. And on ultrasound, there were still some changes that we saw to that supraspinatus and biceps. But on the CBPI, he didn't have any pain anymore. However, his quality of life was still considered fair, and that was because he wasn't able to do all of the things in his life that he wanted to do. So he did still have some activity restrictions, but we didn't think that he was in pain any longer. So that's at 10 weeks. 7 months, this is when I say that we were kind of resolved to the best of what we were going to get. And it was, really quite good. So no lameness, no pain on the CBPI, excellent quality of life. And he was able to participate in all of his activities without any lameness. So sort of the conclusion to this was that the shockwave plus all of the other things that we did, I do believe initiated the healing process. Those activity restrictions were essential, but then that gradual guided return to activity did allow Musket to get back to normal life. Another area that I do use shockwave a lot is with Achilles injuries, and I use it post-surgical because, as I mentioned, after we repair an acute Achilles injury, or anytime we're doing surgery on an Achilles, we're going to put it in some sort of bandage or splint or orthotic or something that doesn't allow that tendon to move. And so I do like the idea of using the shockwave on top of that. But also we see quite a number of these non-surgical Achilles tendinopathies, these the tendinosis, where there's no plantigrade stance, there's no claw paw, just thickening of the tendon. And so one of my patients who was a patient for quite some time, his name was Nitro, And when I first met Nitro, he was 4 years old, male-neutered English pointer, and he was a really high-level hunting dog. And he had an intermittent non-weight-bearing shifting leg lameness for about 6 months. And he was actually referred to me because his symptoms were very similar to a partial cruciate tear. And that's something just to keep in the back of your mind, is if you think a dog has a partial cruciate tear, always palpate their Achilles, because sometimes it's actually the Achilles and not the stifle. And so he was diagnosed with bilateral grade 3, just meaning there was thickening in the tendon, but no rupture of it. Bilateral tendinopathies. So his treatment was shockwave. We did inject PRP, ultrasound guided, and he had custom orthotics made for him. And we transitioned him pretty quickly. If you see the picture, he had the kind of paw segment to the orthotic, pretty quickly came out of the paw segment, and we were able to get him back to sport braces. So he had these orthotics that helped support his tarsus, and he went back to pretty much the same level of hunting that he had for 3 years. Unfortunately, about 5 years later, kind of probably 8 years after I first met him, he was let outside, didn't have his braces on, and ran after a squirrel and completely tore his Achilles. So Achilles are really, 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 really challenging to deal with. But I do think that the shockwave plays a role in helping dogs get back to at least some level of activity, but we've got to consider the other things, the activity restriction and supporting the healing. So moving on to a much, much, much more common condition is our cruciate tears and our surgeries for cruciate disease. And there's some pretty decent research out there that shows that shockwave can help relieve pain post-TPLO, so kind of that faster return to weight bearing, hastens or speeds up the osteotomy healing, and can potentially reduce thickening of the patellar tendon. So really commonly after a TPLO, we'll see a thickened patellar tendon. It was found that shockwave can help reduce that thickening to the tendon. In that particular study, they didn't look at clinical, like the clinical impact. They just looked at the size of the tendon. But when we have in honestly kind of rare cases where we do think that continued lameness after TPLO is due to a patellar tendinopathy or tendinosis, shockwave's a great option for those cases. And then, of course, there's always going to be some degree of OA with our cruciate disease. So another opportunity for using shockwave there. And so I mentioned that the shockwave has been shown to speed up the osteotomy healing for TPLO. It's also been used both in humans and in veterinary patients to reduce or treat non-unions. So in humans, there's evidence to show that with treatment of a non-union with shockwave, there's about a 76% healing rate. So non-unions diagnosed, treated with shockwave, 76% of the time. In this one study, they went on to heal without needing additional surgery. And for reference, success with surgical bone graft is about 79%. So really, really close there. There was also a study that looked at preemptive use of shockwave for potential delayed healing. So these would be like geriatric patients that have a risk for delayed healing. If they were treated with shockwave at the time of surgery, there was a significant decrease in the rate of non-unions compared to historical controls. So on the veterinary side, there have been a couple of studies in experimental dogs, so these aren't clinical dogs, in an acute fracture model, also showing that there's faster healing and a larger callus with shockwave, and also in a non-union model that if it was a hypertrophic non-union, meaning there's still some blood supply there, those could be successfully treated with shockwave. And then there was a very limited case series that was published a number of years ago now, kind of the very, very early days of shockwave in veterinary medicine. And they found that basically 75% or 3 out of 4 dogs that were treated for non-union did go on to heal with shockwave. So in my hands, if I have a patient, a dog or a cat, honestly, that I am worried about delayed healing, let's say they're geriatric, they have comorbidities, for whatever reason, I'm worried that they're going to have delayed healing, whether it's a TPLO or whether it's a fracture repair. I do like to preemptively treat them with at least one round of shockwave. Another area that we don't have research in at this point, but I do use it for all of my arthrodeses to help stimulate healing there. Those can be challenging surgeries to get to heal quickly. So I love shockwave for any time we need to stimulate that bone healing. And then a few other additional indications: lumbosacral disease and back pain. Admittedly, I don't have a ton of experience personally using it for lumbosacral or back pain, but I have some colleagues that have had great results there. Muscle disorders. So an example would be like gracilis myopathy. I have used it in those cases. They're really, really challenging to manage in general, but there's some emerging research that shows that maybe shockwave is the best thing we could do for those guys. Trigger points in myofascial, and then delayed wound healing. So if you're able to see the screen, the picture on the bottom right, I had the opportunity to treat a manatee at Disney World back when I was at the University of Florida. This was a manatee that had been hit by a propeller, had a non-healing wound on his tail, and not surprisingly, the topical honey and other things that they were putting on his tail, and then he'd swim away in the water, that was not helping him heal. But we did get his tail wounds to heal with a few rounds of shockwave. In terms of contraindications, significant coagulopathy. So remember, we're like shaking things up. So if you have a dog that is at risk of bleeding, I wouldn't use it there. I've honestly never been in that situation, but it's a noted contraindication. Not over a fetus. It just seems intuitive there. Not over neoplasia. Same idea. We don't want to increase blood flow to a tumor. We don't want to shake up cancer cells. There's no research to show that it's going to do that, but it just seems intuitive not to treat over neoplasia. Currently not recommended over hemilaminectomy or acute IVDD. I mentioned earlier they're looking at that in humans, but right now we're not recommending that in veterinary patients. The logistics of treatment. It's an outpatient procedure. I tend to do 2 to 3 treatments 3 weeks apart. Some devices do require sedation, and I'll tell you 100% of my experience has been using the device that does need sedation. It is uncomfortable, but in my hands, in my experience, that has not been a limitation at all for using it, and it's just something that we do and get over. But there is the Xtrode with the PulseVet device that now does not need sedation. I don't have any personal experience with that. There's theoretical increased lameness after shockwave treatment. I don't think that I've really seen much of that. You can combine with joint injections, and if I'm treating a joint injury, I would say many, many times I am combining with some sort of injection, and usually PRP. So my kind of series of events is I'll draw the blood while the blood is spinning, I do the shockwave, and then I come back and I inject in the joints. And I think this is another reason why in my hands, the sedation part is just not a big deal, because we're sedating them for an injection anyway. And then, as I mentioned, we do want to shave and use ultrasound gel to improve that transmission of the sound wave through the skin, not through the hair. So that's it for shockwave. Now I'm going to briefly mention electromagnetic field therapy. So completely different type of device. So now we're no longer talking about sound waves. Now we're talking about electromagnetic field. So all of the tissues, all of our cells, we all have electromagnetic fields in our body and in our tissues. And there's, when we have any sort of damage or disease to our body or to our tissues, there's abnormal electromagnetic fields. And so by applying an external electromagnetic field, the thought that it is that can help regulate some of those electromagnetic fields that are out of balance, and then also acts through nitric oxide through some downstream signaling. So the potential benefits of PEMF are improved tissue and bone healing, not dissimilarly to shockwave, potentially stimulating collagen, proteoglycans, and other cytokine release, can potentially decrease pain, decrease inflammation. And there's one particular device called the Calmer Canine, which has been shown to reduce anxiety. And I will tell you, I am actually using that product in my own dog who has substantial separation anxiety. And I do think it works. So there are a few different devices, a few different pulsed electromagnetic field devices out there. The kind of two big brands that really we're familiar with are the Assisi brands, and that is a specifically targeted pulsed electromagnetic field. And then there's also Respond that has a bed. When we talk about research, just like with Shockwave, you can't extrapolate research from one device to all of the others. Potentially it does, but it's not best practice to just assume that because one type of PEMF device showed significant improvement in a study, that is going to apply to all other devices. So the Assisi loop has, as I mentioned, this targeted PEMF signal. And what that means is that through some, quite a bit of research, animal research, also some human research, they designed this electromagnetic field specifically to target nitric oxide. And so there's a specific kind of pulse frequency, a pulse duration, duty cycle, all of these variables that are specific for the targeted PEMF of Assisi. And if you are using a loop, or if you see a loop, the actual electromagnetic field, obviously we can't see it. That field is going to be coming out, I think of it like a sort of like a football. If you put the loop around the football, the field is coming out on either side. One of the great things about PEMF, whether it's in a CC, whether it's a bed format, is it can get through bandages. So we don't have to take a bandage off to actually treat a wound or a bone or anything underneath it. So that's an area that I've been really happy with using it. There are a couple studies that were done looking specifically at the Assisi loop in veterinary patients, and both of them were actually looking at post-IVDD. And my understanding is that these studies were kind of being done concurrently, and I don't know that the authors knew that one another were doing the research. And so in a way, it's kind of nice to have both studies come out with some pretty interesting results. And so the first one came out of Dr. Leilani Alvarez's group out of AMC in New York. And these were dogs that had hemilaminectomy for IVDD, and they were randomized to receive either PEMF or to the placebo group, which was essentially a loop that wasn't admitting any PEMF. And they looked specifically at wound healing, and they did also look at recovery and neurologic function, but they also looked at the amount of pain medications that were needed. And what they found is that pain medications were administered less frequently in dogs receiving targeted PEMF during the 7 days post-op compared to the control. And that was pretty significant. It was a p.01. And then the dogs receiving the targeted PEMF therapy demonstrated improved wound scores at 6 weeks and reduced number of owner-administered pain medication compared to the control group. So their conclusion was that targeted PEMF may improve wound healing and reduce post-operative pain. And the second study was done at North Carolina State, and this was Dr. Olby's group. And they had a little bit different protocol in terms of how frequently and for what duration patients were being treated with the PEMF, again, targeted PEMF, the CC. And what their conclusions were is that there was no difference in gait score or pain perception at 2 and 6 weeks, but proprioceptive placing and biomarkers of spinal cord injury were significantly better at 6 weeks in the targeted PEMF group. And mechanical sensory thresholds were significantly higher in the targeted PEMF group. And that's a good thing. So it didn't take, it took more to stimulate a pain response. So their ultimate conclusion was that targeted PEMF reduced incisional associated pain and may reduce the extent of spinal cord injury and enhance proprioceptive placing. So 2 studies using the actual device that we have available for us in practice. There's still more research that we need for using targeted PEMF any sort of PEMF in many, many, many other conditions, but there is certainly the basic research, basic science research there to support it. In terms of contraindications for PEMF, really virtually none. If there's a pacemaker or any other implanted electrical device, now importantly, that is in the patient, of course, it's being treated. But in my last practice, my rehab practice, we usually had a dog or cat being treated with PEMF while they were being lasered or acupunctured. And if the client was sitting nearby, we didn't want them to be near the PEMF device if they had any sort of implanted device. So it is important to ask that. And I think the way around asking a client, do you have a pacemaker or an implanted electrical device, is to ask them if their animal does, and then kind of explain why you're asking that. And then presumably they would volunteer that information. I would say a contraindication, potentially relative contraindication, is hemangiosarcoma. The reasoning for that is, again, back to the potential increase in blood supply to an area. We don't want to increase blood supply to hemangiosarcoma. I would actually add on to that, at this point in time, if we're going to say hemangiosarc, we'd say any neoplasia. We wouldn't want to treat over that. And then caution using it around metal. Really what that means is don't put the loop on a dog or a cat in a metal cage, because it's probably going to interfere with that signal. And even if you're treating them on a stainless steel table, perhaps don't do that, because it could interfere with that signal. All right, so just want to wrap it up before we take some questions here. Review key points. The indications for extracorporeal shockwave therapy, specifically tissue healing, whether it is bone or soft tissues. Really great opportunities to use it there. We can also use it for osteoarthritis. It may have chondroprotective results. It may reduce inflammation and reduce pain. Can be used for back pain. And there is, quite good evidence supporting the electrohydraulic shockwave device. Again, not to say that other devices don't work. We just can't extrapolate information from one device across to others. And so the limitations of shockwave, that some devices do require sedation for comfort. And again, I think I've broken record here, but we can't extrapolate results between different devices. And then PEMF indications and benefits: pain relief, tissue healing, reduce anxiety, and that's specifically with that calmer canine. Painless, can be used at home, can be used over bandages. So I used a fair amount of PEMF before the pandemic, but absolutely after the pandemic happened and we weren't able to get as many patients in, and we weren't able to do the same level of pain management that we had been doing prior, that's where we really started reaching for targeted PEMF and sending the devices home with clients, and that kind of just increased my, I don't want to say belief, because there's really solid science there, but it improved my appreciation for what we can do with PEMF. And then limitations, again, broken record here, can't extrapolate results between devices. And we do need some more research in other areas. So whether it's OA, post-op orthopedic, soft tissue surgery, but hopefully that research will be coming one day. So with that, I am happy to take any questions.